So we're going to talk about the cardiovascular systems, focusing on the heart and the neck. We have heart and blood vessels. We have two phases, which are diastole and systole. In diastole, remember, our ventricles relax and our heart fills. And with systole, our heart is contracting and pumping our blood into our pulmonary and systemic arteries. We have heart sounds of the cardiac cycle. We have the S1, which is the closing of the tricuspid and mitral valves, which are known as the atrioventricular valves. And we have S2, which is closing of the semilunar valves, which are aortic and pulmonic. So the heart sounds, the lub-dub, is made by the valves that are closing. Then some abnormal sounds that you may come across, S3, which can be benign, but it can be not benign, it just depends. And that's a vibration of the ventricles, and that means that they resist the early rapid filling. Then we have S4, which is much more difficult, and it's vibration of non-compliant ventricles when the atria contract and push blood into them. The sounds also, you may have a murmur, which is a blowing or swishing sound, and there's different kind of murmurs, and you're not cardiologists, so I don't expect you to know the different kind of murmurs. And then you can also have a gallop, which is noted in something like SVT. The heart rate is going really fast. So there are two videos on here that I found that I believe are really good if you would like an A&P review. The first one is about just the blood flow of the heart, and then the second one is about the electrical activity of the heart. When you're watching the second one, he talks about like asystole, but he doesn't note that with asystole, if there's no electrical activity, and so the only thing you can do is compressions. So please remember that if a patient is in asystole, they need compressions and not defibrillation. But defibrillation is when you're in a crazy rhythm, a lethal rhythm. Then we have our neck. And with our neck, we have the carotid artery, which is on the right and the left, and it's located in the groove between the trachea and the sternomastoid muscle. And it closely coincides with ventricular systole. Then we also have our jugular veins, and they help give important information about filling, pressures, and volume changes in the right side of the heart. So if a patient has JVD, they most likely have right-sided heart failure. So interaction with other body systems. The cardiovascular works very closely with the respiratory system. The respiratory system, as you know, exchanges carbon dioxide and oxygen, and this can't be made possible without the circulatory system. The heart gives the deoxygenated blood through the pulmonary system so that it can become oxygenated and go to the tissues and the organs of the body, which is the other thing. We transport oxygen to tissues, organs, and muscles. Then with our nervous system, our central nervous system, the medulla oblongata, it helps regulate our heart rate by the signals that are sent by the cerebrum, hypothalamus, the chemoreceptors, and baroreceptors. Then with our autonomic, sympathetic, and parasympathetic system, they help release chemicals such as norepinephrine, acetylcholine, which affect our heart rate. Developmental changes. We have the foramen ovale, which closes in infancy. It connects our right and left atrium. So if that doesn't close, we can get oxygenated blood mixed with our deoxygenated blood. But a fun fact is almost 25% of the population has a patent foramen ovale, so it doesn't always cause issue. Then we have the ductus arteriosus, which closes, and it's between the pulmonary and the aortic ventricle. So what happens if it doesn't close, then you have oxygenated blood that mixes with deoxygenated blood in the pulmonary system, and the pulmonary system can become congested. And then they also have a faster heart rate in infancy. Then children, and infants really, their apical pulse is displaced because it's more horizontal. They have sinus arrhythmia. They have more common sinus arrhythmia that's related with their respiratory rate. Children also have a faster heart rate. They have more murmurs that are common and innocent, and they could have a venous hum. And the venous hum is best heard above your right clavicle. When you're pregnant, you need an adequate blood supply to the uterus and placenta, so your blood volume increases. It can increase up to 50%, but some sources say 30%, so there's a little bit of variation there. The heart increases, or pregnancy also increases stroke volume and cardiac output, which also increases your heart rate. And then you're going to have a decrease in blood pressure because of peripheral vasodilation. And then as you age, your lifestyle habits will affect anything with the cardiac. So if you had a good lifestyle habits in your youth and middle age, then you might not have so many cardiovascular issues. But if you had bad habits, bad diet, smoking, whatever, then you're possibly going to have more cardiac issues. Increase in systolic blood pressure as you age, and this is because your arteries will become thick and stiff. Your heart size won't change, but you will have left ventricular wall thickening, which will accommodate the vascular stiffening. So as your as the arteries rise in your body, your ventricle on the left side is going to get thicker. And then your diastolic blood pressure is going to decrease after 60. And because of this decreasing in your diastolic blood pressure, you're going to have an increasing pulse pressure. And remember, increasing pulse pressure can be indicative of certain things, such as increased intracranial pressure, or sorry, my dog needs to go outside. So what was I saying? So pulse pressure. So pulse pressure, if you remember, is the difference between your systolic and your diastolic. And as you age, this number can get wider. So the current literature states that a pulse pressure of 60 or greater can be a good indicator of cardiovascular health and like MI. So a person who has a pulse pressure greater than 60 may have leaky heart valves, for example. And then if your pulse pressure is less than 40, it may be indicative of poor heart function overall. And then remember that your older adult is more susceptible to orthostatic hypotension. So some ethnic and cultural variations. About half of African Americans have some form of cardiovascular disease compared to about a third of Caucasian counterparts. There's some belief that there's a genetic component which makes your persons of African descent more salt sensitive, which is why diuretics tend to be a better first-line antihypertensive for this population. Also, there's Hispanics that are about 25% less likely than Caucasian counterparts to die of heart disease. However, this information is kind of paradoxical since Hispanics have a higher rate of diabetes and obesity. So there's some belief that there might be some underreporting. And then Asians seem to have a lower rate of cardiovascular disease. However, if they live a more Western lifestyle, then the cardiovascular disease seems to be just as predominant in that population. So there's some risk factors with heart disease and stroke. We have hypertension, and the AHA, the American Heart Association, recently changed their guidelines. I believe I put a picture of it in here to help you out. Yep. So the normal is less than 120 or less than 120 over 80, and then we have our elevated, which is between 120 and 129. Or that's not the right one. Okay, sorry about that. Now that I have the right picture in here, there are recent changes to the American Heart Association blood pressure guidelines. So a person is now considered elevated if their blood pressure is 120 to 129 for the top number and less than 80 for the bottom number. And they are considered stage 1 hypertensive if their blood pressure is greater than 130, and then stage 2 if it's greater than 140. I know that these guidelines are probably hard to take for people that have been doing this for a long time, But there they are. The JNC 8 guidelines haven't changed. So for JNC 8, it's still 140/90, but I go by the American Heart Association since they are the American Heart Association. Other preventable things that persons can do are stop seeming to smoke. So there's a good education. People that have high cholesterol levels are another risk factor. Those who have cardiovascular disease also have abdominal obesity. So 60% of those with cardiovascular disease are also noted to be overweight or obese, as well as having type 2 diabetes. Those that have type 2 diabetes are at a higher risk of cardiovascular disease. So some subjective data is chest pain, shortness of breath, orthopnea, which is shortness of breath laying flat, cough, fatigue, cyanosis pallor, edema, nocturia, which is going to the bathroom at night. If there's a family history of cardiac issues or a past history of cardiac issues or cardiac risk factors. So some questions to ask during your health history. Pertinent medical history. Do you have any heart problems? Is your heartbeat irregular? Do you have palpitations? Are you short of breath when you're having these palpitations? Do you have a history of high blood pressure? Have a heart murmur? Have you noticed any swelling? Have you ever had any heart tests or heart surgeries? Your review of systems, you want to ask if you have any chest pain, any chest tightness. You want to have them describe their chest pain or chest tightness. And then it's important to remember that women, diabetics, and elderly can present differently. You should investigate any complaints of back pain, jaw pain, or dullness to rule out cardiac disease. You want to ask if the pain's ever associated with certain symptoms such as shortness of breath, nausea, vomiting, sweating, fatigue. Does anything ever trigger this pain? And do you ever have leg cramping? Then you want to question them about risk factors. So how much exercise are they getting weekly? Do you have long periods of standing? Is your cholesterol high? What is your diet like? Have you had any recent weight changes? You want to make sure that you get their current weight. Ask them if there's any use of cigarettes, alcohol, and recreational substances. And it's important in this day and age that we don't forget about electronic cigarettes because they can still, it's the nicotine that's the issue. So if you have e-cigarettes, they have nicotine in them. And then you want to ask if there's any exposure to secondhand smoke. Don't forget the importance of your family history. So you want to ask if there's any history of high blood pressure, stroke, MI, obesity, or high cholesterol. So with your objective data, we're going to inspect, palpate, auscultate. So you want to position them. So for the carotid arteries, they can be sitting, but for your jugular veins and for your chest, they should be supine with their head and chest slightly elevated, about 30 degrees. You want to palpate your carotid artery. Remember to palpate one at a time so that you don't compromise any blood flow to the brain. You want to feel the contour and the amplitude of the pulse. It's usually smooth, and you're going to have a rapid upstroke with a slow downstroke, and it's 2+, which means that it's moderate or expected. And your findings should be the same bilaterally. So the amplitude of the pulse, like how strong is the pulse, basically. So 0 is an absent pulse. If you don't feel a pulse, you need to get a Doppler to ensure before you document and before you call the doctor. If the pulse is weak or you can barely feel it, that is a +1. A +2 is an expected pulse. A +3 is increased, and a +4 is bounding. So I tried to find a way to describe +2, +3, and +4. The majority of you guys are older and you have felt this, so you know. But for those that are newer, I can't really figure out how to describe other than the scale, because I think you just need experience to be able to understand. Like, I don't know how to describe. So if anybody who has been doing it for a while knows how to describe it, please come tell me so I can let people know, because I have an issue with figuring out how to describe it other than the scale. So you're going to auscultate your carotid artery. So for middle-aged or older, or anybody who shows any signs of cardiovascular disease, you want to auscultate each carotid artery for the presence of a bruit. Remember that the presence of a bruit, it sounds like a blowing, swishing sound, which will indicate turbulence. You're going to apply the bell of your stethoscope over carotid artery at 3 different levels, so at the angle of the jaw, in the middle of the neck, and at the base of the neck. You want to avoid compressing the artery, as this can create an artificial bruit. You're going to inspect your JVP, your jugular venous pulse. It's easier to see, but internal jugular vein is attached more directly to the superior vena cava, and it's therefore more reliable for assessment, because if you remember, the superior vena cava dumps directly into the heart. So if you have JVP that is from your internal jugular vein, it's going to be a better indicator of right-sided heart failure. So you can't see the internal jugular vein, but you can see pulsation. You want to position the person supine with 30 to 45 degree angle of their head, wherever you can see the pulsation best. The higher the venous pressure, the higher the position you're going to need, and you want to look for the pulsation of the internal jugular vein at the suprasternal notch, or around the origin of the sternomastoid muscle. If the pulsation is displaced more than 3 centimeters, then you are positive for JVP. So at the chest, you're going to look at the front of your chest. You may or may not see an apical impulse, and it's created as the left ventricle rotates against the chest wall during systole. So when visible, it'll be at the 4th or 5th intercostal space, and it's going to be right at or inside the mid-clavicular line. It's easier to see in children and people who are thinner. So your elderly, frail people, it's really easy to see. You're going to palpate the apical pulse, and the apical pulse, you can localize it by using one finger pad. You want to ask them to exhale and hold it. You may need to roll them to the left to find it, but this will displace your apical impulse further to the left. It's palpable in about half of the adults, not palpable in your obese people or people that have thick chest walls. And then you're going to palpate across your chest, which you're going to use the palmar aspects of your 4 fingers, and you're going to gently palpate the apex, the left sternal border, and the base, searching for any other pulsations. Now remember, the heart is upside down, but you're still palpating at the top and the bottom and the left sternal border. So normally, when you're doing this, you're not going to have any pulsations. Auscultation, you're going to identify areas where you'll listen, which include your valvular areas. The sound radiates with the direction of the blood flow. So remember that your aortic valve is at the second right of the sternal border intercostal space. Your pulmonic is at the second left of the sternal border intercostal space. Your tricuspid is going to be the lower left sternal border, or the 4th intercostal space. And then your mitral valve is at the 5th intercostal. It's very good to remember ape to man. That's the mnemonic that you can remember for aortic, pulmonic, Erb's points, tricuspid, and mitral. And then there's the references for you.